Hey, good morning, everybody. Welcome to Pediatric Grand Rounds. And now I've been asked to keep these introductions short because these people actually need no introduction. So I'll introduce our two speakers for the day. First, Dr. Shaquita Bell, who is the Interim Medical Director of Odessa Brown Children's Clinic and the Medical Director for the Center for Diversity and Health Equity here at Seattle Children's. And Dr. Doug Opel, who's Associate Director of the Truman Katz Center for Pediatric Bioethics at Seattle Children's Research Institute and Director of Clinical Ethics here at Seattle Children's Hospital. Welcome, Shaquita and Doug. Thank you so much for being here.
Thank you. Thanks for having us. We're really excited to be here. I think all of us know that the changing, we were just discussing the changing tide of COVID every day is new. And we started talking about giving this talk a little over a month ago. And I think Doug and I have updated it until this morning. So we're going to do our best to talk about the current landscape as of today and try to have a really good discussion, leave time for plenty of questions and discussion around the COVID vaccine. So as usual, I'd like to start off with a land acknowledgement. First, I'd like to start off acknowledging that we are in the traditional lands of the Duwamish and other Coast Salish people. This artwork was provided to CDHE by a Coast Salish artist, and I just think it's beautiful. This is the black and white version of the image. We do have a color version as well that's on our website. It represents our future and our 7 generations, and I just find that it's so beautiful. I just like to use the land acknowledgement to remind people that our Indigenous folks are still here. They're still stewards of this land, and we'll get a little bit to how they're experiencing COVID at the end of this talk. The other land acknowledgement I like to do is a labor acknowledgement. So I like to acknowledge that this country would not exist or prosper if it weren't for the free enslaved labor of Black people. And we would like to honor the legacy of the African diaspora and Black lives, knowledge, skills that were all stolen through violence and systemic oppression. This is a picture that I took of George Floyd's memorial in Minneapolis. That's now a park. And as many of you know, Minneapolis is in the news for the trial that started this week for, I'm not going to remember his name, Officer Duvan. So just being cognizant of the land that we're on and the history of the land that we're on. So neither Doug nor I have anything to disclose. We do intend to discuss COVID vaccines, which are emergency approved and are technically still being investigated. And they are also commercial products. And then just a reminder that the COVID vaccines are changing all the time, and that what we're going to talk about is what we know right now, but that this will probably change over time. Although Doug and I do not work for Pfizer, Moderna, Johnson & Johnson. So this is what we'll cover. We'll talk about the intention of receiving vaccines. We'll talk about the term vaccine hesitancy and what does that really mean in terms of the science of it. We'll talk about equity in vaccine delivery, and then we're going to hopefully be able to really get into some details on how you as providers and as family members and community members can encourage communication around these vaccines and some tools to talk about it. So we hope that this moves us all to action, and that through the work of our community, we can vaccinate our community and not focus on individuals. That's always my hope, is that we focus on the we, because we're stronger together than we are as individuals.
All right, and thanks, Shaquita, for that beginning. And I'll pick it up with intention to receive COVID-19 vaccines, and I'll talk also about vaccine hesitancy, then I'll hand it back to Shaquita. So before we talk about intention, it's worth sort of reviewing quickly where we currently are regarding vaccine availability. It was a year ago today that the WHO declared a global pandemic, and we already have 3 vaccines authorized for emergency use. Pfizer and Moderna were authorized in December, and the Johnson & Johnson vaccine was authorized recently in late February. The Pfizer vaccine is authorized for use in adults and children 16 or older. The Moderna and J&J vaccines only for adults. And vaccine trials really are already underway that include children down to age 12 with the Pfizer and Moderna vaccines, and Janssen is planning to include children in their J&J vaccine trial soon. Only after those trials are completed will these vaccines be reviewed to determine if they can be authorized for emergency use in children in these younger ages. And regarding distribution, we are still in the early phases of phase one, with healthcare workers having been prioritized first, as many of you know, in December and January. And since late January, our state has moved into phase 1B tier 1 and prioritizing older adults. And you can see the additional tiers here in phase 1B and their estimated timeline, and that some children will become eligible soon in phase 1B tier 2 and tier 3. And children without underlying conditions won't be eligible likely until the summer. And by that time, maybe Pfizer and the other COVID vaccines will be authorized for even younger pediatric age groups. Currently, about 2 million doses have been administered in Washington state, almost 100 million in the United States overall, with that number increasing daily. Yet vaccine demand is still outpacing vaccine supply. And as vaccine distribution ramps up, the objective really is to vaccinate as many people as possible, as quickly as possible. And that in part depends on people wanting the vaccine. And so in that regard, many of us have been keeping our eye on data like this that suggests the intention to receive a COVID vaccine is not maybe as robust as we had hoped. In this study, every 2 weeks from April to December, these investigators asked the same sample of adults what their intention was of getting a COVID-19 vaccine. And as you can see here, early on, early spring, April, there was a high proportion, mid-70s, who responded that they intended to receive a COVID-19 vaccine. But that decreased to, as you see here, the mid-50s by early December. And at this December time point, which by the way was right before the Pfizer vaccine was authorized for emergency use, this intention to receive a COVID-19 vaccine varied among subgroups, with a lower proportion of young adults and Black adults intending to receive a vaccine and a higher proportion of white and older adults intending to receive a COVID-19 vaccine. But here's an important point. My intention in showing these subgroups is not to single out any particular subgroup, but rather to emphasize that there's hesitancy in all subgroups. If we, in fact, consider a target vaccination threshold of 70%, say, of the population, which many consider to be the herd immunity threshold to prevent further spread, we fall short of that target across all subgroups, as you see here. If we use a target to get as many people immunized as possible to prevent further hospitalizations and deaths from COVID, you can see we have a long way to go in all subgroups. There is some evidence, though, that intentions to receive COVID-19 vaccines may be improving among the public. In a different survey by the Kaiser Family Foundation at 3 different time points, participants were asked, have they received a dose of a COVID-19 vaccine, and if not, when one becomes available to you for free, do you plan to definitely not get it only if required, wait and see how it's working, or get it as soon as you can? And you can see here this group in orange, the wait and see group, a group really worth paying attention to because they can go either way. They're sort of on the fence. Reassuringly has decreased steadily from about 39% in December to 22% just last month. And other polls have shown similar reassuring trends. What is less reassuring is the proportion of people in these other two groups definitely not going to get it or get it only if required. This has been holding steady around 20% since December. And when we drill deeper among the wait and see group in February, that 22%, we again see differences within groups. So proportion is lowest among older adults, highest among Black adults, but you'll also notice not an insignificant proportion of healthcare workers were planning to wait and see in February, 14% to be precise. And when combined with the proportion in the same survey of healthcare workers who said that they would only get a COVID-19 vaccine if required or would definitely not get it, 21% in those two groups, that's a high proportion of healthcare workers who are hesitant, about a third of all respondents in this survey. So this hesitancy or reluctance among healthcare workers has been even higher at previous time points. In this series of survey studies measuring vaccine intent among healthcare workers at different U.S. health systems, you can see the proportion who planned to wait and see were not sure they'd get vaccinated was nearly 70% in September and October of 2020. That has since fallen to about 30% and maybe even further based on the data I showed you in the last slide. But there are some important things to glean from these surveys. First, there are differences in vaccine intent by clinical role. In that survey in September, October, investigators found 48% of physicians surveyed were in this wait and see or not sure group, 80% of nurses, 69 to 70% of other personnel with or without direct patient contact. Second, a few reasons why healthcare workers were hesitant rose to the top. Among those who said they were not sure or were definitely not vaccinated in that November, December survey, perhaps not surprisingly, the top two reasons they gave were concern about adverse events or side effects and concern about short or long-term efficacy. Now, most of the surveys that have been done so far have queried adults, given the vaccines were anticipated to be available to them first. But there have been a few surveys that query a parent's willingness to accept a COVID-19 vaccine for their child. This is one of them, done by an international group that actually includes our own Julie Brown and Eileen Klein. And they surveyed about 1,500 parents who came to EDs in 6 different countries early in the pandemic, so March through May of last year, and asked parents, if a COVID vaccine was available for your child, would you give it and get it for your child? I found 65% at that time said yes, the rest no, and you can see some of the reasons here for acceptance. I would get it to protect my child, to protect others, as well as reasons for declination. The newness of the vaccines being a chief reason, as well as low perceived risk of their child getting COVID-19 and concern about vaccine safety. So with that introduction around intention to receive, let me just transition to COVID-19 vaccine hesitancy in context. And I think it's important to put some context here, as I think that can help us understand why we are seeing some of this reluctance, as well as point to possible strategies to help reduce this hesitancy or reluctance. And I'd like to focus in on 3 sort of contextual features. First, the pre-pandemic milieu, the milieu that existed before COVID hit regarding vaccine hesitancy. And then also, secondly, features really that are specific to this really historic moment we're in, not only regarding the pandemic itself, but also the development of a vaccine as a countermeasure. And then, third, the renewed strain that the pandemic has put on the social contract that is vaccination. So I'm going to go into each of these in more detail. So first, the pre-pandemic milieu. I mean, it seems like ancient history now, but these are some prominent examples of the milieu before the pandemic. The proportion of parents refusing or delaying childhood vaccines was increasing, such that, as you see there in green, 2.5% of all U.S. kindergartners had their parents exempting them from required school entry vaccines in 2019. In other words, vaccine hesitancy was already very much on the rise. And not surprisingly, as more parents opted their child out of required vaccines, more children went on or under immunized and were more likely to develop and transmit disease. And as a result, we were seeing more outbreaks of vaccine preventable disease. In fact, in 2019, we had the worst measles outbreak in the U.S. in 20 years, as shown there in orange. And this was remarkable for many reasons, but one was that we have a safe and effective vaccine to prevent a measles outbreak in MMR that's been around for decades. It's readily available. It's recommended universally for children. And it was this that parents were choosing not to accept. And we reached such a critical point in 2019 for these reasons and others that the WHO declared vaccine hesitancy as a top 10 threat to global health. So this was the milieu sort of entering into COVID, a milieu in which the pump was primed for being reluctant or hesitant about vaccines. So some of the hesitancy, I think, also is likely due to some of the historic firsts in vaccines we are currently experiencing. So, for instance, the Pfizer and Moderna vaccines were the first vaccines developed using messenger RNA technology. And though the science behind mRNA technology is not new, it's about 3 decades old, Pfizer and Moderna are the first manufacturers utilizing this technology to make their vaccines. The second reason is that the COVID-19 vaccines are the first vaccines made available to the broader public through an emergency use authorization. There's only been one other instance in U.S. history where a vaccine has been made available by EUA, and that was the anthrax vaccine in the wake of the anthrax bioterrorism terrorist attacks in the early 2000s. And even then, it was only made available to high-risk groups, not the broader public. So these firsts have understandandly had an impact on people's willingness to accept a COVID-19 vaccine. We saw that in the parent survey described before, and in another recently published survey of adults, this newness of a COVID-19 vaccine was cited as a top reason for having low trust in a COVID-19 vaccine, this being a representative quote. I would not feel comfortable with any vaccine without having seen more research and long-term trial results to gauge the safety of the product. This newness, in fact, I think has enhanced the importance of trust. In fact, at the core of this new process that we are being exposed to of issuing an emergency use authorization for a COVID-19 vaccine was weighing the costs and benefits to society, making a judgment call. Was a vaccine safe and effective enough given the cost of the pandemic? And to have confidence and trust in a decision like this, we needed transparency. We needed transparency so we could know that our individual health and the public's health were the primary interests driving this decision. And unfortunately, transparency was lacking leading up to the first EUA being granted in December, not only about the COVID-19 threat altogether, but in the EUA process itself, with the politicization of this process, implying that the FDA was not being transparent with us about the standards it was using to issue an EUA, perhaps not basing them in science or safety, but instead to help or hurt a political party. And this really compromised public trust and confidence, not only in the FDA, but in public health authorities more generally, and the government altogether. And we saw this in survey studies that came out soon thereafter. In fact, in October and November, in a survey of healthcare workers, it was found that 34% didn't trust the FDA to oversee vaccine development and safety, and 46% didn't trust information from the government about COVID-19. This historic moment really has resulted in some historic mistrust. And along these lines, the pandemic has put a renewed strain on the social contract. If the social contract at its core is citizens giving up some individual freedoms in exchange for the state or government maintaining social goods like security, like public health, the pandemic has once again exposed that the social contract has never been reciprocal for many Americans. As Shaquita will discuss soon, there are disproportionate risks for COVID-19 associated illness, hospitalization, death among people of color, and there's been disproportionate access to COVID-19 vaccines among people of color. Viewed this way, vaccine reluctance among people of color in particular is not about vaccine safety or newness necessarily, but about systemic social injustice. Freedoms have been given up, but little or no security or health has been given in return. And as James Baldwin wrote in the 60s, that is unfortunately still true today. Allegiance, after all, has to work two ways, and one can grow weary of an allegiance which is not reciprocal. Indeed, most members of BIPOC communities are not confident that the needs of their communities are being taken into account with respect to COVID-19 vaccines. Among Native Americans, for instance, 32% are concerned that Native people are being used as guinea pigs or test subjects in vaccine trials. Among Black Americans, only 10% are very confident that COVID-19 vaccine distribution is taking the needs of Black people into account. And among Latinx Americans, only 47% are confident that a vaccine will be tested specifically for safety in Latinx people. And this has an impact on vaccine acceptance. As of December, for instance, though 55% of Black adults are worried about either themselves or someone in their family getting COVID-19, only 49% plan to get vaccinated once eligible. To achieve vaccine acceptance among BIPOC individuals, we need to understand that any reluctance towards a COVID-19 vaccine, again, may not be rooted in the vaccines themselves, but maybe primarily in their current lived experience of discrimination and racism. And we need to lean into these discussions of those experiences rather than shy away from them. And at the same time, realize that those discussions themselves may be insufficient. We have to be moved to action in other ways. We need to connect with the communities our clinics serve, partner with community leaders, hear their perspectives and stories, acknowledge their concerns, and show how we are working to mitigate the inequities they're experiencing. And with that, I'm going to hand it back to Shaquita to discuss promoting equity further in vaccine delivery.
Thanks, Doug. It's always a little hard to follow somebody who never says, because I do it too much. So the next couple of slides, I'm actually not going to talk a lot. I just want to show some data and just let it sort of soak into what COVID has been doing to our communities. This information comes from the Kaiser Family Foundation. So this is the number of COVID cases based on self-identified race. Again, people are only offered these buckets, so you may not identify as Asian American, but that might be the one bucket that is as close as possible to how you identify. So this is inequities. And then the next slide is hospitalization. And then the next slide is mortality. And then the next slide is life expectancy. So I ask you, when you see these numbers, what does that mean to you? And I'll tell you a little bit about what it means to me. So when COVID started, one of the first things that came to my mind is how are our communities going to be impacted? And specifically, how is my community as a Black Indigenous woman, how will it be impacted? And I thought, I'm going to work every day and risking my life at that time, not knowing how this infection was spread or how to adequately protect ourselves. And I said, well, if I'm willing to do that, what else am I willing to do? And I enrolled myself in the AstraZeneca study that is happening here. So I'm still in that study, and I feel like I should share that with you all to be completely open about my feelings on the COVID vaccine. But one of the drivers of doing that was really to address some of those questions that Doug brought up on a second to last slide about these vaccines being investigated in our communities and making sure that they are safe. And so I felt, as a Black Indigenous person who doesn't have kids that rely on me, who doesn't have an elder who relies on me, that I wanted to volunteer. I wanted to be a part of that. And I think that's a common thread. At least I know several people on Twitter. I don't know if "no" is a strong enough word. I'm associated with enough people on Twitter to know that I'm not the only person who did that. And I know that many of us in our community wanted to protect our community. And so next slide, please, Doug. One of the things that I think is important when we talk about these things is we talk about the we instead of the me, or the we language of something that is good for all of us is good for each of us. And that's a really strongly held belief in Indigenous communities. We also believe that the elders are our story keepers, our knowledge and culture keepers. And so if we can do something to protect them, to protect that knowledge, to be around longer, we will do that. And we recognize that the disproportionate impacts of COVID-19 in terms of infection, mortality, hospitalizations are driven by things such as systemic racism, as oppression, as the history of boarding schools and reservations, in terms of how our healthcare is delivered through IHS. And for those of you who don't know, urban Indian health programs, tribally run health programs, and IHS clinics are all funded through the federal government, through HHS and through IHS subsequently. And it is considered as part of the appropriation, so it's not permanent funding, and they only receive approximately, I'm not going to remember the exact number, $4,000 per person for healthcare. And I'd like to put that in perspective. The federal prison system receives a little over $7,000 per person per year to provide healthcare. So we devalue our Native communities in this country, and I believe that's part of why COVID hit so hard. Next slide, please. So this is from Abigail Echohawk. She is a senior leader at the Seattle Indian Health Board and at the Urban Institute of Health Information. And one of the things she said, and one of the things we've been trying to get awareness around, is that Native communities are really interested in preventing COVID from taking our elders and our story keepers away. One of the things that Moderna and Pfizer did really early on is directly partner with some tribal groups like the Navajo or Dene down in the Southeast to see what the vaccine may be able to do in these communities. So that was a really exciting development. And I think what's important when we think about vaccine, with the language around vaccine acceptance and vaccine hesitancy, is to be careful, and much like Doug was in the first part of this talk, is to not use vaccine hesitancy to lay blame. So on the next slide, I talk about how you can use the term vaccine hesitancies to start to blame certain communities. So it puts the emphasis and the fault on the person or the patient instead of really on the system, or for instance, on the politics that Doug mentioned earlier, that really bred some of the fear, that really bred some of the uncertainty, because we have a challenging time in America getting truth out, getting clear information shared to our communities. And then it's also really a convenient excuse not to address the inequities of the disease burden, right? If we just blame, for instance, Black people for not getting vaccinated, then it doesn't really challenge us to provide vaccine to those communities. And what I am always inspired by Dr. Rhea Boyd, who, as you all know, gave grand rounds last month. She is really leading this work, and she has this New York Times article out. She has a new article out in The Nation, and then she launched a program to offer advice directly to our community, our Black community, around getting the vaccine. And she says we must be clear that until we have equity in vaccine availability, we cannot blame vaccine hesitancy on the rates. So I wanted to take a moment and just share what we're doing at Odessa Brown. The state DOH approved us to be able to give vaccines to BIPOC and immigrant communities, and we chose to focus on Black, Indigenous, immigrant, and families who speak a language other than English to deliver our vaccines. And this is something that is not a new idea. This is an example of Navajo Nation. This is their numbers. That it is daily. It's updated daily on their website. I just pulled this in February, at the end of February, for our slide presentation, but they're doing a really great job, and you can see that they have really delivered the vaccines, and we're hoping to sort of mimic that at Odessa. So we have a vaccine clinic on Sundays that provides vaccine to everybody in tier 1A and 1B who qualify. We partner with the Somali Health Board, the African American Health Board, Living Well Kent, and El Centro de la Raza to make sure we're targeting our vaccine delivery to those communities. And then we also are going to launch a vaccine clinic starting after March 22nd for our Black, Indigenous, and immigrant communities in terms of our patients and families. And we are really lucky at Odessa that we use some flags, some tools in Epic to be able to identify our patients in terms of their medical history and verify that they are eligible for the vaccine. And so we will work together to launch that vaccine clinic starting on Saturdays at the end of this month. So I think one of the hopes that I provide in the takeaway from my portion of this talk is that when we talk about vaccine hesitancy, we also need to talk about vaccine availability and vaccine acceptance, and that there are many people in our communities who really do want this vaccine, and the way that it's being rolled out is making it very challenging for people to get access. But with that said, let's say that you are not of the community and you want to talk about or think about ways to get the vaccine and to get the vaccine distributed and to make it available. The Urban Indian Health Institute did publish a toolkit on ways to think about how to improve vaccine acceptance and availability. And this is straight from their document. They really believe that we need to center this discussion around cultural values, that we need to partner with urban Indian and tribal clinics to lead the efforts. We need to find effective ambassadors in the community. That's one of the reasons why Odessa is partnering directly with community groups like Somali Health Board. We need to acknowledge the historic and current harms that have been perpetuated by healthcare, much of which Doug covered. The fact that we haven't earned the trust and in respect of these communities, and we haven't provided that even up until today with access to testing and disease impact. We need to ground the vaccine campaigns in community participation. And then we need to recognize that vaccine acceptance is a spectrum. That's one of my favorite things to remember, is that just because you're vaccine hesitant doesn't mean that you won't accept a vaccine. And I can say firsthand from delivering almost 500 vaccines in the last 2 weeks, that there are a lot of people who have questions, a lot of people who are really nervous and really anxious. They still get the vaccine, but they need somebody they trust to talk to them about it, to answer their questions. And that's such a privilege for me to be present and to meet these folks where they're at, provide the vaccine while I'm also answering their questions and their concerns. So moving on, we really wanted to talk about some key ways that you all could talk about these vaccines and how to communicate around COVID-19 and COVID-19 vaccines. So Doug's going to start, and then I'll pick it back up on some strategies to do this.
Thanks, Shaquita. I think so important in what Shaquita said is these discussions can happen and they're really impactful, but they're not the only thing we can do. We need to be doing the partnering with communities and outreach that Shaquita mentioned. But given that many of us are having clinical visits and vaccine clinics now, there are things we can do in these interactions with patients that can really be influential. As we've been suggesting, COVID-19 vaccines are not routine vaccines, and these are not routine circumstances. So in many ways, we have to break from some of our routines and how we begin these discussions, the words we use, and how we might respond to their concerns. So Shaquita and I have detailed a approach for doing this in these two publications, and we'll briefly review that approach here, but we can't get to all of the specifics. So please look at these documents in more details if you're interested. And I'll also say that one of our pediatric residents, Kat Songer, has worked with our Department of Health to put together a discussion tool for clinicians that is in part based on this approach. And we'll put a link to that tool on our last slide so you can reference that too. But the approach Shaquita and I came up with really is around these 4 specific strategies that you can consider using right now in discussions with patients and parents about COVID-19 vaccines. Leading with listening, tailoring responses to parent concerns, using accessible language, and acknowledging uncertainty where it exists. And I'll talk about these first 2 and then hand it off to Shaquita to talk about the last 2. First, leading with listening. Now, this is a change I want to just sort of be explicit about from our standard vaccine communication practice. For routine childhood vaccines, many of us for DTaP, MMR, flu are accustomed to beginning the vaccine discussion using what's called the presumptive format. That is to presume the parent will be fine with vaccinating. And so we often say something like, Sarah's due for 3 vaccines today, MMR, varicella, and pneumococcal vaccine, period. Now, this is justifiable given our certainty that these vaccines are high benefit, low risk. Making something like simple consent here, but appropriate, simply explaining the intervention and getting agreement. And it's worth noting that we have this high certainty because these routine vaccines have been comprehensively studied for many decades and have received full approval by the FDA, universally recommended by federal advisory committees. This is not yet the case with COVID-19 vaccines. Though they have shown incredible promise, they have not yet received full approval because in part we do not yet have this high certainty that they are high benefit, low risk interventions. They're still unapproved biologics made available for emergency use. And as a result, we should use a different approach for this vaccine discussion than we use with routine vaccines. And we should not, we argue, begin the vaccine discussion making assumptions or presumptions. Rather, consider beginning the COVID-19 vaccine conversation with an open-ended invitation for the patient or parent to share their perspective. Something like, you may be hearing a lot about COVID-19 vaccines. Tell me what you think about that. Doing so helps us realize the type of informed decision-making for COVID vaccines we should be aspiring to, given the lack of certainty we have at this point around COVID-19 vaccines, benefits and risks. But it also helps achieve the type of interactions patients, particularly those from marginalized communities, desire, in which their experiences are heard and validated. Second, tailor your responses to patient or parent concerns. If a parent responds to an invitation to share their perspective with a, I'm not sure, or those vaccines aren't for me or my child, resist the urge to provide reassurance prematurely. Doing so may be ineffective if it's done before listening to and exploring further the parent's concerns in more detail. Rather, engage with the parent non-judgmentally and collaboratively. Don't try to automatically persuade. And motivational interviewing techniques can really facilitate this type of engagement and have actually been found to be effective in improving vaccine uptake among those who voice reluctance to routine vaccines. So if a parent says something like, after inviting them to give their perspective, saying, I really don't know what's even in these vaccines, a response that acknowledges that concern without judging and then creates a space for you as the clinician to address their specific concern might be something like, the information is just starting to come out. So having questions like these are totally normal. May I share what I know about what's in these vaccines? Now, there are 6 good MI skills to consider incorporating into COVID-19 vaccine discussions. Some of these may feel familiar, others less so. One that might feel familiar is use of open-ended questions. These help us identify, explore, understand the patient or parent's COVID-19 vaccine concerns, saying something like, can you tell me more about what's worrying you? Reflection and affirmation statements, too, encourage partnerships, deepen rapport, help patients and parents feel supported, appreciated, understood. So if a parent expresses concern about the safety of COVID-19 vaccines, you can respond with a reflection statement like, I hear that you want to be sure that COVID-19 vaccines are safe for you and your child. And similar, if they voice other concerns, an affirmation statement might be, you're not alone. Several of my patients have similar concerns. And then ask permission to share puts parents and patients in a less defensive posture, improves receptivity to information you want to share with them, rather than just launching into information about a COVID-19 vaccine that you want them to hear. Start with, may I share my view with you or my medical perspective with you? It can improve the likelihood that they actually hear what you have to say. And then statements that support autonomy, enhance the parent's sense of control, helps them feel more at ease. I want you to know that this is your decision to make. Enrolling with resistance, encourages us as clinicians to meet resistance with curiosity rather than confrontation, and that can encourage more engagement from parents and patients. I'm hearing that you don't think you'll get the COVID-19 vaccine anytime soon. Tell me more about what is concerning you. And importantly, your vaccine recommendation as the child's clinician, which is known to be strongly associated with increased vaccine uptake generally, can be integrated with MI. Consider, for instance, asking permission to share your recommendation. And if granted, saying something like, in my view, the benefits of COVID-19 vaccination far outweigh the risks, and strongly recommending these vaccines to my patients. And before I hand it off to Shaquita, here are just some example responses using MI techniques that you might consider using to common parent or patient concerns. For instance, if a parent says, I just think this has gotten really political, you can consider saying something like, you're right, it's gotten political, simply reflecting. And then after listening and further exploring parents' concerns, consider, here's what I can say. I've looked at the results of the vaccine we have to offer. The vaccine does really protect people from COVID. I want you to have the benefit of it. Similarly, here, if you get the vaccine, you can get deported. Way to respond using MI would be, what a frightening thing to hear. Can you tell me more about what you heard? Open-ended question and reflection. And after pausing and listening further, consider, I want to assure you that no information about immigration status is collected when you get vaccinated. It's important that everyone who needs this vaccine is able to get it. And lastly, I read on social media that the risk of COVID is not that high. Consider, it's true that COVID can affect people mildly or severely. May I share my medical perspective about this, though? So using ask permission to share. And then if given permission, consider, my colleagues and I are seeing enough severe cases of COVID that our hospitals really are so full that they cannot do everything they would like to for patients. There's a daily newsletter from the Department of Health that shows the latest numbers that I can share with you. Over to you, Shaquita.
Thanks, Doug. So a couple of other examples of how to communicate around these topics is one, use accessible language, right? So the use of emergency use authorization. While that is true, that's exactly what it is. It may sort of be confusing, right? If you don't know what that means, and it may also lead to even more mistrust. So instead, consider something like, go ahead, Doug. Short statements like the FDA has authorized these vaccines and now are reviewing the information or the evidence really carefully and ongoing. One of the things Doug pointed out at the beginning of this talk is that the mRNA technology itself has been around for decades. So helping people get information that's accurate but also accessible. So in other words, not speaking like a doctor, but speaking like a person is what I like to remind our students. And then acknowledge that folks may be uncertain. That's a lot of what I was talking about doing in our vaccine clinic at Odessa, is that these are uncertain times, right? All of us are uncertain and we don't know what's going to happen tomorrow, much less next month. So it is wise to acknowledge that, and it creates transparency. It also really creates a bond between you and the person in front of you, right? When you acknowledge yourself that you don't know what's to come, but we know the evidence that we have around these vaccines, and that I like to personally share my journey in being a participant in the clinical trials to say, well, I can't predict the future and I don't know what's going to happen even tomorrow, who knows, when we wake up in the morning and read the newspaper. But it is really important to think about what is that, where does that uncertainty lie, and what can we do to make ourselves feel all that more grounded and all that more connected to our community. And that's why I feel like this idea of doing something for the greater good, for the we, or for our community, is so important. And when I share that with families, I can feel what a bond that builds between the two of us. So we just want to thank you all. We're going to provide a couple of resources. It looks like there is, Christina P's put in the chat the latest portal to the DOH. I'm going to include the link that I mentioned around Rhea Boyd and doing work for the Black community. Their website is betweenusaboutus.org, and I just put that in. And then this is the DOH guide that was built with one of our residents, and some of the work that we've done at the University of Washington as well to build some tools for providers to use both in their patient population, but I also find, on my own family Zoom calls with my uncles and aunts and cousins and nieces and nephews. So we can't have, it doesn't feel like we can have too many tools. I think with that, we'll pause. And Doug, anything else you wanna add? Oh, thanks, Kat, for putting that in the chat there.
Yeah, thank you all. Happy to take questions.
Thank you so much, you two, and for everyone who's putting links in the chat. We can save this and make sure it's sent to all our participants along with your evaluation. Emily Rice, hopefully you're okay with me offering that service, but we'll make sure to get these links to everyone who needs it. And there's one other, you can go ahead and put your comments and questions in the chat. There's one other that I'll just read out, even though I think you two can probably see it. This is such an important grand rounds. I have heard and read in patients' charts things like parents refused vaccines and verbal handoffs that feel judgmental when a caregiver or parent isn't comfortable with or is behind on vaccines. We can all do better and provide more support and compassion. Totally agree. Alicia Adele.
Yeah, thanks, Alicia. I think it's such an important point, and that's why I said sometimes we use this science of vaccine hesitancy. I don't mean that, sorry. I meant this in terms of the way we use it, it is a science that Doug just presented. I feel like we can weaponize it against our patients and families and communities, and that's where we need to be careful and to be cognizant, because while hesitancy is real, it's human nature, right? To be unsure, especially at a time where we're unsure about so much. It's human nature to be worried, to have questions, to be unsure. And we don't want our brains as clinicians, as healthcare providers, to use that to shift blame to the patients. Really, it is our job to provide information. It's our job to read all these really exciting FDA trial documents and synthesize that into a language, into terms that people understand. But for the most part, as many of you remember when you train to be the clinician you are, it is our job to build trust not only with yourself, but with healthcare in medicine in general, and to help people have a safe place to go. Doug and I were talking the other day about how it feels like there's this war being waged in the media in terms of trying to control like what people can handle, what information will be effective in terms of like do we tell people how bad COVID really is, or will that just result in panic? And it turns out, and I think I can say this pretty confidently, that truth is good and that we should be truthful, and we shouldn't try to use manipulation to control the way people think or feel, and that sharing what we know turns us into humans, but also being truthful builds trust. I don't know if you want to add to that, Doug. I think the media is they're not my favorite thing right now.
I will only add, that was a great answer, that, the COVID situation aside, with routine vaccines, I mean, it's such a polarizing topic that it's easy for us as clinicians to sort of adopt this us against them approach. And we have to remember to sort of take the humanistic side here and assume all parents are just trying to do what's best for their child, and approach those discussions, however frustrating they might be, with that humility, with that compassion, with that empathy. And I think vaccine hesitancy is a modifiable behavior. We can help families who are uncertain or unsure feel better and reassured by taking that approach most of the time. I totally agree with you, Shaquita. In this, and in particular in this COVID-19 situation, I mean, there's so much uncertainty, and we're in unprecedented times. I think having that approach is essential.
Thank you.
Oh, Christina, that's such a good question. It was actually what I was going to ask. So I realized, statistically speaking, based on the slides that Doug showed, that at least some of you may be hesitant even on this call. And even though we're mostly healthcare providers who access this portal through Seattle Children's page, that there may be some of you on this call who are hesitant yourselves, or who have coworkers like Christina who are hesitant. And I'm curious if we can have a discussion about what does this really mean? So Doug and I aren't here to just talk at you. I would love, maybe Christina, you could come off mute and we could talk about like the brass tacks of doing this in your clinic, and what does that look like? I'm putting you on the spot, Christina. She might not be in a place to come off mute. Can she come off mute? Will the Grand Rounds let her do that?
Emily Rice is the goddess of mute, so she can unmute. Now, Pease, if you're listening, Emily, can you unmute Dr. Pease? It can happen if she wants it to happen. Let's see.
Oh, all right.
Oh, we have her. Yeah.
Hi, Christina.
Maybe. I'm gonna share a story while we figure out unmute. So at Odessa, we had virtually 100% of folks who provide direct patient care in terms of APPs, MDs, residents, et cetera, were vaccinated, but only 25% of our, of our MAs. And I was really struck by that. And again, we're not requiring the vaccine, and I don't know specifically who has it and who doesn't have it. But one of the things that we did together is that we took a document that was intended to increase people's skills for talking to their patients and families about vaccines, about COVID vaccines specifically. And we asked the MAs to work on it with us. And so we specifically said, okay, here is this information. How would you address this question with a family member? And what do you think about this response if your doctor said this to you? And through this process of working together as a team to sort of create some tools for our patients, our families, and our providers to provide information, our vaccination rate actually went from 25% to 100% in our MAs. And that's because we worked together. It was really one of the first times where us as providers said, hey, these folks, our coworkers, are not just our coworkers, they're also our community. They're also the very people that we're trying to have this conversation with. And so I felt like it was such a great example of building that trust and sharing truth and really getting down to what is the fear, where does that lie, where does that come from, and how can we address that. It's such a great way. So Christine, sounds like you might be off of mute now, maybe. This is fun. This is a fun experiment. What will happen next? I don't know, Doug, if you want to go back to the healthcare slide, we could share that, because one of her questions was what people are seeing elsewhere in their clinics. I've only seen, like, on a individual clinic level, I've only seen our data at Odessa.
I can try to go back.
Sorry, Christina. It looks like you're
The double mute.
a challenge. Yeah, she.
So yeah, I also heard Jeff Sparing shared with me that I can't remember which children's hospital in Ohio, one of the children's hospitals in Ohio, only 40% of their team was vaccinated.
I can't see the chat, but any other questions in the chat, Suzanne?
Yes. A comment from Catherine or Kat Songer. Thank you so much for this talk. I also want to emphasize that leading with listening and being curious is such a great way to get to know your patients better. I've been asking parents in clinic about COVID vaccines, and I'm learning so much more about my patient families and their motivations than ever before. It not only helps answer their questions and concerns, but also helps me feel closer to my patients. Thank you for that. Agreed.
Yeah. So, and follow up to that, thank you, Kat, is, these conversations don't have to wait. I mean, these should be happening now. I mean, health supervision visits with, healthy kids and parents of those kids, even though they may not be eligible for a vaccine for a number of months, start these conversations now and help explore with parents any concerns they have. And so that once vaccine, they are eligible for the vaccine, there won't be sort of a lot of things to cover, and we will have many parents ready to be on board.
So, for you guys. Oh, go ahead.
I was just going to say, Tamani asked a question, but she's having trouble asking it to the whole group, so I think she sent it to me and Doug.
Okay.
Her question is, can you talk about this approach might be different or the same for immigrant families who have additional uncertainties from their home countries' experiences in healthcare? I can start with saying one of our approaches is to make sure that the care, the entire experience of a patient from the time they enter the building to the time that I have a conversation with them is provided in the language that they speak. So at our vaccine clinics, we're having folks meet families at the door and saying, what language do you prefer? And then walking them through even the registration process with interpretation. But I think your question is really important, Tamani. I think reflecting on what somebody's experience before the moment you got to know them was and what healthcare is like in their country, I think is really important. And I think these tools work for that too. So starting with listening, asking, out of curiosity, what has your experience been with vaccines in the past? Or tell me more about what it was like to receive healthcare as you were growing up, or what are some of the concerns you have about your previous experiences that may hold true for what's going on now. One of the things we found in January is a lot of our immigrant communities were really traumatized by the experience of what happened at the Capitol, and how that really that brought back so many memories of wartime and of coups and things like that, that it was really important to have a moment to talk that through. The other thing we haven't mentioned, which I know Doug will co-sign, is the fact that we need time to do this, right? Like you can't be looking at the clock or your watch and saying, okay, I have to see my next patient in 10 minutes. We really have to be able to settle into these conversations. And I'm not sure that our current structure always allows time for that. Anything you
Yeah,
add?
I would just emphasize the approach Shaquita and I advocate for really has generalizable components, namely, as Shaquita said, leading the listening and not assuming, and focusing on the patient in front of you and their lived experience, is really critical here. And I think that is broadly applicable to all our patients.
Okay,
can you guys hear me now?
Yes, we can.
Yay! No, so I am at CMAR, so it's a federally qualified health clinic in South Seattle. And so we've been vaccinating for the community, and we are on Phase Finder. Just as a summary, interesting enough, when we first opened, I would say, most 98% of our population are Latinx, our patients, and we've been vaccinating quite a bit. I would say 20% of those getting the vaccine from our clinic are actually Latinx. So mostly we are serving non-BIPOC communities as a community site, but CMAR's approach is indeed to make something accessible and coming from our clinic. And we now just got approved to get Moderna in order to vaccinate our own patients. So we'll have some additional supply specifically for our own patients. So it's indeed every day I walk into work, a very different experience of people upset that we've run out, but also quite jarring that the patients we're trying to serve and get vaccinated are not the ones who are coming to our clinic for that. And like I said in the chat, we're 50% of our staff in my specific clinic, but I think it's CMAR wide, and we have clinics all across the state. Indeed, we're not quite up to the herd immunity that we need to make our workplace safe for us and for our patients. And in probing a little bit more with what the reasoning is we've uncovered some of the medical assistants who were most fearful, quote unquote, and then they use that word fearful in the beginning of the pandemic when we didn't have enough PPE, and I would argue to say we still are struggling with good PPE, are the ones who are not wanting the COVID vaccine. And so I think this pandemic highlights how much everything is interconnected. It's bringing in science, it's bringing in emotions, it's bringing in all of our humanity. So I've really tried to ground myself in acknowledging my own fears, what I'm bringing home to my family, how long it's taken to feel some relief after having been vaccinated, and sharing in that humanity in my conversations with my families, and truly doing like what Shaquita is doing, is sharing her own choice to participate in a research study. And we also are a research site for Novavax. So we have a young man from UW recruiting our patients. And he actually has, so without making assumptions that, oh, he'll never recruit anybody, he's actually recruiting quite a few. So if given the time and the space for somebody who's dedicated to have these long conversations and heart to hearts, that's what I'd encourage us all of us to do with whatever emotional stamina you have that day, and checking in with yourself. I guess that's my current journey as of today.
Thank you for sharing.
Really, really powerful.
Christina, we get our vaccine through Seattle Children's, which obviously is through Phase Finder and through the state. But what we discussed with Department of Health is to be able to specifically target BIPOC and immigrant communities. So it is not an open to the public vaccine site at Odessa. Children's is, but at Odessa, we have permission to specifically partner with communities. And that's the way we've been able to have nearly 98% of our vaccinated people are BIPOC or immigrant. And it's been phenomenal. So we call Somali Health Board on Monday and say we have 200 vaccines to give away on Sunday, and then they enroll their community. And we partner together, and every week we get better and better in terms of how to offer assistance to the community groups too, because they're not healthcare providers, right? They don't have the infrastructure to screen whether you've had immunoglobulin products in the last 60 days. So we partner together, and we've gotten better and better at it. But that's one of the ways that we've tried to really specifically make sure we're serving our community. And I'd be happy to talk to you more about that, because we were worried if we opened it up to the public, we would see lines of people around the block who do not reflect the community we're trying to serve.
Yeah, I can't speak for my administration, but they've been very active with the governor and in Olympia to advocate. And we are a family health clinic. So we serve a large, not just pediatric, I mean, obviously. So there's larger issues in terms of a lot of our patients are uninsured, as opposed to what we as pediatricians have, our children who are insured. So they got a lot of support. And I think it was pretty, in a lot of what CMAR does with our addiction treatment programs, is making it accessible and just throwing that in as providing for the community at large in order to provide and improve access to our specific underserved population.
Yeah, we're doing all adults, right, until March 22nd. I will say, just a reminder for everybody, that you do not have to have insurance to get the COVID vaccine, and we do not require, should not, it is not a state requirement or a federal requirement to list documentation status or citizenship or anything like that. So in other words, you should be able to get a vaccine with your first name, your last name, and your phone number and date of birth.
Thank you. Thank you to all three of you and everyone who's on this call. Thank you so much for all of your advocacy and work. I wish we could talk for longer, but it's already 9:01, so we're going to let everybody go. But we really appreciate this information and everything you guys are doing for our communities. So thanks again. And thanks to all of you for your participation. We'll see you all next week.